Good morning, everybody. I'm Desai from Cleveland Clinic in Cleveland, Ohio. Welcome to my hometown, bright and early. And
I'm Desai Owens from the University of Pennsylvania, not my hometown, but I'm happy to be here even though it's windy and a little bit cold. Good morning,
good
everyone.
morning, everybody. Thank you for coming, and hope all of us have fun, entertaining next hour learning about HCM and evolution of cardiac myosin inhibitors. So these are some of the things we would like to sincerely thank Bristol Myers Squibb and peer for sponsoring this event, but peer review CME for developing this session. Hopefully everybody has completed the pre-survey and look for the polling questions and submit the questions for Q&A. These are some of the slides. What do we need to achieve here? How CMI's cardiac myosin inhibitors work, who is an ideal candidate for being treated with a cardiac myosin inhibitor, how best to incorporate CMIs in the treatment of patients with obstructive HCM, and what's cooking, what's coming next in non-obstructive HCM and heart failure with preserved ejection fraction. Before we begin, please select your degree. And please select your specialty. All right. How many patients in the past month with suspected or diagnosed HCM have you treated? And which of the following practice settings is applicable to you? All right. Now let's get to the crux of the matter. Which imaging studies would you order to diagnose HCM? Transthoracic echo, cardiac CT, CMR, PET, transthoracic echo, and CMR, I'm not sure. Order everything. So. All right. And based on your experience in treating HCM and the available evidence, how would you recommend using cardiac myosin inhibitors and disopyramide? CMIs should replace disopyramide. CMIs should be used in combination with diso. CMIs should be used only if a patient cannot tolerate diso. Leave the choice to the patient after discussing benefits and limitations of each approach. More information needed, I'm not sure. And how many imaging studies will you tell patients they need in the first year of mavacamten use? At least 3, at least 5, at least 7, at least 9, 10 or more. I'm not sure. A patient with non-obstructive HCM and LV ejection fraction equaling 60% has insufficient symptom relief on a beta blocker and a diuretic. Which medical therapy do you offer next? Disopyramide, aficamten, mavacamten, valsartan. Enroll in a clinical trial. I'm not sure. Okay. Let's understand what the gaps are in diagnosis and treatment of hypertrophic cardiomyopathy. Again, I'm Milind Desai. HCM is an equal opportunity offender. It affects both sexes, all race, and all ages in all places. Okay? This has no geographical preponderance or otherwise. The population prevalence is thought to be between 1 in 200 and 1 in 500. So just by that simple math, there are millions of patients worldwide with HCM, more than 20 million. There are clear disparities in treatment and in hospital mortality that have been documented, specified based on race, gender, insurance status, rural versus city location, region of the country, size of the hospital, as well as hospital profit versus not-profit status. Female patients are diagnosed later than male patients. Median age at diagnosis is thought to be about 46 years. Heart failure and atrial fibrillation may not be present at diagnosis and they may evolve. So if this is a genetically mediated disease and the age of diagnosis is 46, that means not everybody turned a switch and developed hypertrophy at 45 years and 11 months. Most of them are underdiagnosed or diagnosed with something else. Race, black people, black patients have more heart failure symptoms and less often referred for symptomatic management. This is unfortunately not just specific related to HCM, but across the spectrum of diseases as we unfortunately recognize. So at the very least, underdiagnosis and undertreatment are rampant in this disease. What happens to a hypertrophic cardiomyopathy heart? At the base is alteration of myocyte energetics and with a preponderance, with a predisposition to developing congestive heart failure. It starts obviously subclinically. You may have what we call phenotype negative, genotype positive status. Then as life occurs, puberty and beyond, there's development of LV hypertrophy. The classic phenotype in HCM, as all of us know, is somebody with hypertrophy, most commonly seen in the basal septum. And if you evaluate carefully, they have the phenotype of dynamic outflow tract obstruction, LVOT obstruction, obstructive cardiomyopathy, which is seen in about 70% patients. About 30% patients have the non-obstructive phenotype. The classic phenotype is seen in about 75% patients with an ejection fraction of more than 65%. And often these are stable. A well-managed patient in this classic phenotype by an experienced provider has a long-term outcome outlook similar to an age and gender matched normal population. Then there's the unlucky few, or however you look at it, develop adverse remodeling. The prevalence is thought to be about 15%. They develop the HFpEF phenotype, and then there's a even smaller proportion that develops overt LV dysfunction. I dislike the term burnt out HCM. Try telling a patient you have burnt out something. People don't like burnt toast. So, heart is a big, big deal. So you have developed a phenotype of overt LV dysfunction, which is about 5 to 10%, where your EF drops to less than 50%. How do you diagnose HCM? According to ACC/AHA guidelines, suspicions obviously are raised by symptoms, family history, an event, heart murmur, abnormal ECG, abnormal echocardiogram. And patients emerge in your practice any one of these ways. How do you evaluate these components? You take a 3-generation family history. Physical examination is not overrated, should be done and done thoroughly. 12-lead ECG, echo, a well-done echo with appropriate provocative maneuvers, Exercise echo, especially if there is no resting or Valsalva LVOT gradient that is in the severe range greater than 50 millimeters of mercury. CMR, cardiac MRI, offers complementary value in addition to a comprehensive echo, especially if the echo is inconclusive. And genetic testing is something that helps guide family screening as well as downstream counseling. Imaging is essential to the diagnosis of HCM. Make no mistake about it. Diagnostic threshold for what is the definition of obstructive HCM, especially latent HCM, is anything greater than 30 millimeters mercury outflow tract gradient. It is often and very commonly associated with systolic anterior motion of the mitral valve, otherwise known as SAM. The most recent ESC guidelines have emphasized the role of multimodality imaging in diagnosis of HCM. If you clinically suspect HCM, it is used, multimodality imaging is used to assess phenotype, rule out phenocopies, stratify risk for progression of disease, as well as long-term follow-up. And echocardiography is the mainstay first line for LV function, hypertrophy, dilation, but CMR clearly offers complementary value. In addition to all the things that echo does, it can do tissue characterization, including T1 mapping, T2 mapping, T2 star, fibrosis mapping. Functional abnormalities at peak stress can be ascertained by stress echocardiography. Not only it looks for obstruction, but what's cooking with the valve, what's cooking with the subvalvular apparatus, papillary muscles, etc. More and more now, a lot of patients end up having coronary CT angiography, and we are finding an increased prevalence of myocardial bridges and the downstream ramifications for that. Additionally, some of the multimodality imaging studies like the technetium pyrophosphate scan to rule out amyloidosis is important because imaging is getting more ubiquitous. We are diagnosing a lot of elderly patients, and sometimes these things go hand in hand. About 10% of an HCM population or an aortic stenosis population may have concomitant amyloidosis. PET-CT, not always used, but occasionally could have a role in terms of if you suspect concomitant inflammation. So, complementary role of echo and CMR to measure LV thickness. Sometimes echo can be challenging. Identifying the trabeculation on the RV side may be difficult, and especially at the fringes. Low wall thickness, where you want to make a diagnosis of HCM. Is it 14 millimeters? Is it 15 millimeters? You're changing somebody's life. Is it 30 millimeters? Is it 27 millimeters? You are potentially going to offer them a defibrillator. It is important to be precise here, and CMR can provide incremental value in addition to what echocardiography can do. Another important aspect of HCM and imaging is the increasing focus on non-obstructive and apical variant HCM. As you can see the image on the bottom left, the apex is not well visualized on this echo. If you suspect apical HCM, it is imperative that you obtain appropriate windows and give contrast to look for the apical variant as well as the apical aneurysm. CMR has much better spatial resolution, and it does a much better job of identifying the apical variant HCM as well as the presence of apical aneurysm and if there's a concomitant thrombus within. This is a busy slide for reading at home, but using various features on echo and CMR, including multiparametric imaging on CMR, you can differentiate between HCM, amyloidosis, Fabry's, hypertensive heart disease as well as athlete's heart. Beyond wall thickness, how is the T1 map? What is the degree of fibrosis? Is there a specific pattern of fibrosis? Do you have on edema-weighted imaging on MRI? Do you have any specific pattern that may point towards concomitant myocarditis? Amyloidosis has a very different looking LGE pattern compared to HCM. Sarcoidosis looks different. Athlete's heart has some features that it shares with HCM, but then at the end of the day, it's a normal physiologic condition. So multimodality imaging helps us derive a firm diagnosis when it is in doubt. Well, sometimes natural humans need artificial intelligence, and now there's significant impetus and emergence of these AI systems that can detect anything and everything. But in the context of HCM, there is this commercially available products now which can utilize mobile apps to identify, based on a cadre of ECGs, it can identify if your patient has an HCM pattern. This is the brave new frontier where you can send in millions of ECG and you can get a report back that 100 of these patients have HCM. Go work them up. So that will perhaps help move the needle of making the diagnosis in the right direction. So VizAI just became the first FDA-approved HCM detection algorithm. So more to come in this space. Not just ECG, echo, CMR. No matter whatever you have, you can apply artificial intelligence. So, follow up to the polling question. Rethink your answers. Which imaging studies would you now order to diagnose HCM? TTE, CT, CMR, PET, echo, and CMR? I'm still not sure. There you go. Yeah, I think echo is generally the first line, but vast majority of us in an HCM practice I would agree with that they would strive to go for echo and CMR, unless they have a pacemaker, non-conditional pacemaker that's not compatible with CMR. So it is my tremendous pleasure to introduce Dr. Owens, who will level the playing field.
Thank you. Let's jump in. We're going to talk about whether or not cardiac myosin inhibitors are a valuable option to fill unmet needs, particularly in obstructive HCM to start. So let's start with a case study. This is a man, William, age 58 years old. He has a long-standing history of dyspnea on exertion, which is a very common complaint, as you all know, in cardiology clinics, and also some exertional chest pain. His past medical history includes asthma, hypertension, and acid reflux, and he is on albuterol, omeprazole, losartan, and metoprolol. So again, a pretty typical combo. And on your very important physical exam that Dr. Desai said we can't forget to do, you hear a harsh systolic ejection murmur at the left upper sternal border. And you assess his symptoms to be NYHA functional class 3, meaning limitations with just slight exertion, going up the stairs, for example. Here's his ECG pictured on the right with left ventricular hypertrophy and the kind of classic strain pattern and repolarization changes. And here's his echo, pictured on the top left is the parasternal long axis view, and you can see asymmetric septal hypertrophy. You can see systolic anterior motion of the mitral valve. Let's see if I have a pointer here and I can point it out. Maybe not. Up in the top left there. And then you can see the Doppler profile where we importantly assess the hemodynamics of the ventricle and see if there is any evidence of cavitary or outflow tract obstruction. And you can see the measurement there on the Doppler that his LVOT gradient is 57 millimeters of mercury. And as Dr. Desai said, really anything over 30 millimeters of mercury tells us that there is some obstruction to the flow of blood. His MRI is pictured on the right, and we won't go into too much detail, but suffice it to say that there is a significant amount of late gadolinium enhancement that is present in sort of a patchy distribution. So here is our patient. Now, what is the diagnosis? Is it 1, mitral valve prolapse, 2, a dilated cardiomyopathy, 3, a non-obstructive HCM, 4, an obstructive HCM, 5, restrictive cardiomyopathy, 6, more information is needed, or 7, I'm not sure. And everybody got it. Even bright and early, everyone recognizes this correctly as obstructive HCM. So what are the first-line treatments? Say this patient arrives to your office, has class 3 symptoms, dyspnea on exertion, chest discomfort. You've diagnosed him as obstructive HCM. The first thing that we do is really assess whether or not there is anything that he's taking or anything in his lifestyle that may be exacerbating LV outflow tract obstruction. And we think that most of his symptoms are on the result or as a result of obstruction to the flow of blood. So the first thing to do is to talk to your patient about whether or not they're staying hydrated and whether they're on any offending agents, and this would be vasodilators that decrease afterload and by doing so can exacerbate LVOT obstruction, or whether they're taking something like a diuretic, which is going to decrease preload and again can exacerbate LV outflow tract obstruction. So in this patient, he's on losartan, which potentially could be exacerbating his symptoms of outflow tract obstruction. He's also already on metoprolol, which is a non-vasodilating beta blocker, which would be the first line of treatment. So one thing that could be done in this patient is to peel back the losartan, particularly if there's no other reason why he's taking it, that he needs it, and maybe titrate the beta blocker in conjunction with asking him to stay well hydrated. We usually tell our patients at least 64 ounces of non-caffeinated beverages per day to make sure that his ventricle stays nice and full. And if those things don't work, then you would think about adding on another therapy, or particularly with class 3 symptoms, whether or not he might be a candidate for septal reduction therapy. So those would be the first sort of attempts. Anything else you would do for this patient, Dr. Desai, on first line?
Perhaps consider screening for sleep apnea. That's kind of goes hand in hand with, and also be aggressive about looking for occult arrhythmias if not already done.
Definitely. So Holter monitors would be indicated in patients like this every year or so to make sure you're not missing any arrhythmias. So from the natural history studies in SHARE, which is an international registry of patients with hypertrophic cardiomyopathy, it's now up to 10 or 12,000 patients. This publication happened a bit ago, 2 or 3 years ago, and it showed that about 1 in 6 patients with HCM develop severe heart failure symptoms during their time in this registry. And this is New York Heart Association functional class 3-4 symptoms. Now, importantly, this is not all heart failure with a reduced ejection fraction, and we define that as an EF of less than 50% in HCM. We're not saying that all of those patients developed systolic dysfunction in HCM, but rather that they had congestive symptoms on the basis of outflow tract obstruction or more of a HFpEF phenotype in non-obstructive HCM. So these people can still have a preserved EF or severe outflow tract obstruction and get severe heart failure symptoms. So what advanced therapies do we use when patients are very symptomatic and you've already tried the first-line therapies, which are your beta blockers or calcium channel blockers, and peeling back anything that's potentially harmful? Well, that's where we really start to think about whether or not you would use disopyramide, which, as we know, has potent negative inotropic effects, but is an antiarrhythmic medicine. Unfortunately, has some supply chain issues and many side effects in terms of anticholinergic side effects. And if not, or at the same time, we would often talk to patients about whether or not they want septal reduction therapy. And as you know, that comes in 2 flavors, at least here in the US. We typically use surgical septal myectomy, best done in expert hands at expert centers to get the best results, or alcohol septal ablation, where expertise is still very important, but maybe not as important as open heart surgery. And at the same time, we talk to patients about whether or not they might be a candidate for a cardiac myosin inhibitor. On the basis of the VALOR trial, my colleague here was the first author, we know that mavacamten was beneficial in those patients, all of whom were considering septal reduction therapy, greater than 90% of whom were New York Heart Association functional class 3. They benefited from mavacamten and were able to delay or prevent the need for septal reduction therapy. And we'll talk a little bit more about that in the slides to come. So about 1 in 5 patients in the SHARE registry required septal reduction therapy during their tenure in the registry. So again, not an insignificant number of patients who in their lifetime will be facing a decision of whether or not they need gradient reduction therapy. So where do the cardiac myosins fit in? These are small molecules that are being evaluated in clinical trials. There is one currently FDA-approved agent, that is mavacamten, which is the first-in-class agent. The way these drugs work is by modulating contractility. And so that's a very important kind of basic premise to think about as you work with these drugs and start to prescribe them. They modulate contractility, and we're taking hearts that are hypercontractile, they're beating too forcefully, and we're bringing them down a notch to beat more normally. By mechanism of action, if you get too much of one of these medicines, there's a chance that your ventricle will become hypocontractile. So that is systolic dysfunction. It can be asymptomatic or symptomatic, but that's really what you're watching for as you modulate the contractility in these patients. You're trying to get them to the sweet spot. Aficamten is a next-in-class cardiac myosin inhibitor. It's still in clinical trials. It is not yet FDA approved. It has a bit shorter half-life than mavacamten. So these drugs, this class of agents, are the first that have been developed to target the underlying pathophysiology of HCM. So as opposed to beta blockers, calcium blockers, disopyramide, which as you all know were developed for other reasons, this is the first class of medicines that targets the problem with HCM. So let's look a little bit at the long-term effects of mavacamten. As you all know, EXPLORER was the pivotal phase 3 trial that led to the FDA approval of mavacamten. And all of those patients from that parent study were offered the opportunity to go into the long-term extension trial, which is open-label use of mavacamten for obstructive patients who were symptomatic. And you can see at week 48, at week 108, and week 120 at the bottom that we saw a significant improvement that was sustained in terms of New York Heart Association functional class improvement. Now, there is a drop-off of numbers over time. Not all of the patients have reached that week 120. We have several patients at our site who have, and they have sustained, durable effect in their functional class improvement, which is really nice to see in this patient population, with 70-some% of patients getting improvement by either 1 or 2 classes. This is a study that was recently published, and this was kind of an explorer-type study, but performed in the Chinese obstructive HCM population. This was looking at mavacamten versus placebo in 81 patients, and there were 2 notable changes here. One is that mavacamten was started at 2.5 milligrams. Here in the US, we typically start patients at 5 milligrams, and that is what the recommended starting dose is, and the dose that was used in most of the trials to date. This one used 2.5 milligrams, and the reason is the lower body weight in the Asian population and a higher prevalence of the poor metabolizer phenotype, and for that reason, a lower dose was started. And a peak VO2 was not part of the study. They were looking at gradients and functional class, and you can see pictured here, although I think the legend is missing, but you can guess which line belongs to which agent. So placebo is in yellow, and the mavacamten line is in blue. And what you can see with resting and Valsalva gradients is a very substantial drop in gradients. And again, these patients were sick to start. The peak gradient Valsalva was above 100, resting gradients in the high 70s, almost 80. So these were patients with severe obstruction. And their functional class, as you can see on the right, improved significantly in the mavacamten group, with 40-some% of patients class 1 at the end of 30 weeks. Now, interestingly, the dose was titrated, and so you can see at the bottom that the typical dose that patients were on by the end of study were similar to what we see here in the US, with most patients being between 5 and 10 milligrams of mavacamten. No patients reported an LVEF less than 50%, and no other major toxicity or new side effect was noted. So let's switch over to aficamten and the latest data from aficamten. These results were published within the last year. This is the Redwood HCM phase 2 dose-finding study, and there were 3 cohorts. Cohort 1 and 2 were placebo-controlled dose finding, and you can see by the bars in cohort 2 that at the higher dose of aficamten, we saw a similar improvement in NYHA functional class with about 65% of patients reporting an improvement. Cohort 3, I'll call your attention to. This was an open label cohort. These were patients who were very refractory to medical therapy, all of whom were on disopyramide, in addition to an AV nodal blocker. So we added CMI to that already dual negative inotropy. There were no major side effects. This was mainly done for safety, and that 85% NYHA functional class does reflect, I think, in part an open label design. When you look at the change in left ventricular ejection fraction for the cohorts versus placebo, again, by mechanism of action, we expect to see a small decline in ejection fraction. In aggregate, they remained above 50% in the normal range. So let's talk a little about the long-term effects in VALOR and what we saw in those patients who were all eligible for surgical intervention. These were patients who were actively considering SRT, class 3 patients. At the beginning, I'll just remind you of the trial design. We were looking at the primary outcome of proportion of patients who either proceeded with septal reduction therapy or remained guideline eligible by gradients and symptoms. And so at the beginning, 100% of the patients were eligible for SRT. And then over time, and I'll remind you, this was a crossover trial. So the original mavacamten group on the left, after 16 weeks, the primary endpoint, down to 18% of patients from 100 who were still guideline eligible or underwent SRT. And by week 56, down to 9%. Now the crossover group, which is on the right, again started on placebo, so it's 16 weeks, 77% still eligible, and then you can see a marked decline when they got the active treatment, down to 14% and now around 19%. So again, showing durable response to mavacamten and the ability to delay or even prevent, we need longer term data to say that, but certainly to say delay the need for SRT. And the gradient reduction, you can see here, was substantial, starts at week 4 and then progresses down, and you can see by week 16 in the mavacamten group in blue, and then the placebo to mavacamten group in orange. And they cross once the placebo group gets access to the drug after week 16, and a durable response, a significant response, with many patients with gradients, you can see there, at rest under 20 millimeters of mercury, which is our definition for saying you have obstructive disease. NYHA class, this is pretty dramatic, with 93% of patients reporting improved NYHA functional class by 56 weeks. Always important to look at safety endpoints. So this is a novel class of medications. Our eyes are tuned to the left ventricular ejection fraction, and in the mavacamten group, we saw that there was permanent discontinuation in 3 patients. This was due to 2 of them having an LVEF less than 30. If that occurs, by protocol definition, it was a permanent discontinuation, and 1 patient who had 2 consecutive LVEFs less than 50, despite the lowest dose, and that person also permanently discontinued. There were a total of 12 patients who had an EF of less than 50. That can be a transient drop in most patients. So 9 out of 12, 75% of patients who had a drop in ejection fraction to less than 50 were asymptomatic and able to resume mavacamten. And I would say this is the more typical pattern, that you pick it up on a screening echo. The echoes are done for safety precisely for this reason. You get an ejection fraction of 48%. Your patient feels fine. They have no idea that this was happening. You temporarily stop the drug. You bring them back in 4 weeks. The ejection fraction climbs above 50, and you restart the drug. That's a pretty typical pattern when this occurs. The more rare frequency of occurrence, but very important, is a patient who has a clinical event. And often this can happen in the setting of atrial fibrillation, particularly rapid atrial fibrillation, where you'll get a drop in ejection fraction that can be symptomatic. And again, the right answer is to temporarily stop the drug. These are reversible cardiac-specific drugs. The ejection fraction comes back up, and then you're able to resume at a lower dose. So aficamten has completed enrollment of its phase 3 pivotal trial. That is the SEQUOIA-HCM trial, and we would expect a readout of that trial sometime in 2024. The baseline characteristics were presented actually by Dr. Marin here at the HCMS meeting on Friday. And this was a very international cohort, and it also included patients from China, about 17% of patients from China. Mean age was right around 60, 40% female. The NYHA breakdown here is more similar to the Explorer group than the Valor group, with 76% of patients being class 2. A host of background therapies. The percent of patients on beta blockers was capped in this study, so fewer patients on beta blockers than were in Explorer. And you can see the mean peak VO2, these were limited patients at 18.5, and a KCCQ score that's a little bit higher than what we saw in Explorer at 74. This may represent geographic diversity in KCCQ in the way patients report their symptoms. We found in the Asian population that patients are less likely to complain that they're feeling poorly. This is the MAPLE HCM study design, phase 3 study. This will compare head-to-head aficamten versus metoprolol. So this will be a very exciting study to see the results of. The first time we're testing standard of care versus aficamten. I'm going to have Dr. Desai take over for me. Okay. This is the HFSA preview to look for a few abstracts, looking at echo in the real world, and also looking at racial ethnic diversity in the real world treatment of patients with mavacamten. All right, just on time. Woo.
Perfect timing. So, all these Kaplan-Meier curves and all these fancy data, how do you integrate CMIs into the clinical workflow? This is a team sport. HCM is a team sport. It requires multiple members of the HCM care team, the cardiologist, advanced heart failure team in some cases, structural intervention, cardiac surgeon, primary care, research team. Now, every HCM patient is a potential for some form of research discussion. Wellness factors, we have to talk about lifestyle, nutrition, well-being. Understanding of genetics and advanced cardiac imaging is crucial as part of your team. So this involves, because a lot of this is shared decision making, right? So HCM cardiologist, primary cardiologist, EP, genetics, etc. Patients are savvy. Patients know a lot more than you think they do. And now, more than ever, they're asking a lot of pointed questions. And they expect to work collaboratively with you as the healthcare provider. And they will talk to each other on Facebook Live and Instagram Live and whatever Gram Live that is out there. So they do talk. What do the ESC guidelines say about treating HCM? If you have a symptomatic patient with NYHA class 2 or 2 to 4, if you have AFib, that's, you need to get ahead of it. AFib is a bad actor here. It will mess up your best day at the office. Rate rhythm control, anticoagulation. There is no CHADS-VAS score here. If you have documented AFib, you go on anticoagulation. Cannot underscore the importance of that. If you are still symptomatic, and if you have LVOT obstruction that is more than 50, then you go the pathway of LVOT management. If there is no LVOT gradient, the key here is a good quality echo, okay? Not using the full extent of provocation to designate somebody as non-obstructive is inappropriate in 2023. Having said that, you convince it's non-obstructive, then what's your EF? More than 50%, then you talk about standard therapy. If it is less than 50%, then heart failure guideline-directed medical therapy, beta blockers, ACE, ARB, MRA, things I cannot even pronounce this early, SGLT2, low-dose diuretics. And then beyond that, if the writing's on the wall, then mechanical support devices, cardiac transplantation. But a lot of these drugs are not disease-modifying therapies, okay? How do you treat? So to be continued, let's continue. If you have gradients greater than 50 millimeters of mercury and you are symptomatic, first line is beta blockers. If you still remain symptomatic, the ESC guidelines talk about verapamil or diltiazem as class 1. If still symptomatic, then diso or mavacamten. Mavacamten got a class 2A indication. If still symptomatic, proceed to septal reduction therapy. I'm going to tell you one thing. The only prospective randomized controlled trial data in this space exists in mavacamten. Everything else is, they get a class 1 indication, but level of evidence is C. Expert consensus opinion, observational studies, or retrospective data. So these are quote-unquote guidelines, okay? They are not Rosetta Stone, my opinion. None of them are disease-modifying therapies. So where do cardiac myosin inhibitors fit in the management of obstructive HCM? As Dr. Owens has mentioned, treat comorbidities, remove the bad triggers. If you avoid, this is a big one, right? Avoid vasodilators and diuretics. Move to beta blockers. Move to verapamil, but there is an argument based on the Explorer data that can be made to move to mavacamten after beta blockers. If they still remain symptomatic, there's conversation about using disopyramide or, based on the VALOR data, mavacamten. But as Dr. Owens mentioned, disopyramide has a lot of side effects. It's like a mother-in-law. It takes a while to get used to, and even then, you may or may not get used to it. Okay? I said it. If that doesn't work, then you proceed to SRT. If you are a surgical candidate, then you proceed to surgical myectomy. But you need a center of excellence with an experienced surgeon to be able to do that. If you have a good surgeon, mortality is 0%. If you have an inexperienced surgeon, your mortality can be up to 16%. Published data. Alcohol septal ablation in patients who are not typically candidates for surgical myectomy. So this is basically the schemata that is proposed right now. And this obviously will evolve as time goes on. If you are not very symptomatic and well controlled, then reevaluate in 1 or 2 years. Polling question. Based on your experience in treating HCM and the available evidence, how would you now recommend using CMIs and disopyramide? CMI should replace diso, should be used in combination with diso, should be used if a patient cannot tolerate diso. Leave the choice to the patient after discussion. More information needed, I'm not sure. All right. What would you do,
split
Dr.
here.
Owens?
Interesting split. You know, I do leave the choice to the patient, and I give them all the options. But we don't have a whole lot of patients choosing disopyramide once they think about the side effect profile, or they try it and then they experience the side effect profile.
So I'll just talk about my practice 2 miles east of here. Before mavacamten came about, our use of disopyramide was about 3 to 5%. Now, in the last year, at least in my practice, I've not started anybody on diso. So, what do you need to know about mavacamten and the REMS program? REMS is what? Risk Evaluation and Mitigation Strategy. This was put in place based on the strong recommendation by the FDA. It is fundamentally recognizing that reduced ejection fraction may occur, reversible, sometimes irreversible. So LVEF monitoring is needed. Don't initiate if it is less than 55%. Interrupt if it drops to under 50%. Drug-drug interactions can increase the risk of heart failure because of the CYP450 inhibitor inducers, the CYP cytochrome pathways. So it is important to check the medication list. Thank God for electronic medical records, so they flag us if we are trying to do something stupid in our practice. So it is good, but no new prescription or non-prescription medications should be started without discussing and checking the DDIs. And all of us need to be on the same page. This is a team sport. I tell the patients it's about rights and responsibilities. You have rights, but you also have responsibilities. All of us are in this together. It requires ongoing echo to monitor structure and function prior to initiation, 4, 8, 12 weeks, 4 weeks after every dose increase, and every 3 months. So if you're a business person in your medical practice, this is a good echo growth opportunity, but be it as it may, this is something mandated by the FDA, and it is required to do. Fundamentally, mavacamten has substantial net benefits in obstructive HCM patients, including improving survival and quality of life. But the imaging burden is something that also always should be discussed. How many imaging studies will you now tell patients they need in the first year of mavacamten use? 3, 5, 7, 9, 10? Sky's the limit. Yeah, 7. Good. Excellent. What is the real-world data coming at AHA? Dr. Anjali Owens is going to talk about, I think you will be, right?
Dr. Noshin Reza
Okay,
will
Dr.
talk about
Reza,
it for us.
or your team, will talk about single-center experience with using mavacamten. Treatment adherence to mavacamten in the US, adherence are study, and multidisciplinary care management of patients with mavacamten for obstructive HCM. So look out for these. And now I toss it back to you, Dr. Owens.
Thank you. I'm going on the record to say that my mother-in-law is more like mavacamten, effective, durable response, not disopyramide. All right.
Mine too. But
Beyond,
I think.
beyond obstructive HCM, what's next for this class of medication? So I'll call your attention more towards the middle to bottom of the slide, where we have the Odyssey HCM phase 3 trial for non-obstructive HCM. This is mavacamten versus placebo. We talked a little bit about Maple HCM. That's another phase 3 trial. That's obstructive symptomatic HCM with aficamten. And finally, the Acacia HCM trial, another phase 3 non-obstructive HCM symptomatic patients. This is aficamten versus placebo. So we have our work cut out for us to enroll these several hundred patient trials in the next year or two. So here's a patient of mine, Sophie, age 62, family history of HCM. She's had AFib that's been ablated. Her maximal septal wall thickness is 2.6 centimeters. She has a VUS and MYBPC3, not a pathogenic or likely pathogenic variant, but a positive family history. Class 2-3 symptoms. She's on a calcium channel blocker, a diuretic PRN. She's on anticoagulation, as Dr. Desai said, for her AFib. Here's her ECG, which shows evidence of left ventricular hypertrophy, some nonspecific changes there. And here is her echo. This is hopefully going to play. And you can see asymmetric septal hypertrophy that extends down into the apex. Her NT-pro was 1,300 and change. No gradient at rest or with Valsalva. Her peak gradient was 5. And she has evidence of elevated filling pressures, E over E prime, that's elevated. So what is the diagnosis here? Mitral valve prolapse, dilated cardiomyopathy, non-obstructive HCM, obstructive HCM, or restrictive cardiomyopathy. More information is needed, or I'm not sure. All right, and the answer, yes, is non-obstructive HCM. So you've done provocable gradients to make sure that there is no obstruction. She has septal hypertrophy, and she meets the criteria for non-obstructive HCM. So what do we have in the guidelines, 2020 guidelines, for patients with non-obstructive HCM who are symptomatic and their LVEF is greater than 50? Not a whole lot. It's sort of the same host of characters: beta blockers, calcium blockers. Give it a try, see if they feel better. Sometimes patients feel worse if you do too much AV nodal blocker. For a patient with non-obstructive HCM, you cause chronotropic incompetence, and actually their exercise tolerance can diminish. If they have congestive symptoms, you can try diuretics. Some people use loop diuretics, others use an MRA, but still not a whole lot of benefit. This is a tough population to treat. So our patient decided to go into the MAVERICK study, which was the phase 2 study, mavacamten in non-obstructive patients who are symptomatic. And here's her heart after mavacamten, after 4 years into the long-term extension. And you can see her systolic function is not appreciably changed. It's still normal. She still has her septal hypertrophy going down into the apex as well, and her gradients remain low. But what was remarkable were the changes that she had in diastolic function and her symptoms. So she went from class 2-3 to class 1. You can see her NT-proBNP came way down, from 1,300 down to 200, and an improvement in non-invasive measures of filling pressures with E over E prime improved. So this was really dramatic for this patient and in several others who we follow. This is another thing that I'm starting to notice, and I'd be curious if you are as well, Melinda, is changes in EKGs that are pretty dramatic. This is 4 years later, pre-mavacamten. You can see with voltage coming off the page, and her voltage has improved considerably on mavacamten.
I mean, I have to say, yes, we have seen that, and, a naturally dumb cardiologist like me can evaluate. You don't need an artificially intelligent machine to look at that. The changes are pretty dramatic when you see them. Yeah.
That's right. And this is long-term data that I presented on Friday at the HCMS meeting. This was the cohort of patients from the parent MAVERICK study, which is that phase 2 non-obstructive HCM dose-finding study, mavacamten. These are patients that are cohorted and now into the long-term extension study, so open label. And this shows their improvement in NT-proBNP over the time frame up to 120 weeks. And what we saw was a dose-dependent, so the way that MAVERICK worked and the LTE of MAVERICK works is that patients were randomized to 2 different target concentrations, so 200 nanograms per mil or 500 nanograms per mil. So we did see a dose-dependent decrease, but overall the cohort dropped their NT-proBNP by about 50%, which again is remarkable in this population. You can see the LVEF graph on the right. In aggregate, these patients stayed above 50, but there were individuals who dropped their left ventricular ejection fractions to less than 50% and required temporary holds of the mavacamten. And again, in this dose-finding study, we did find that happened in a significant proportion of patients. And that dosing strategy informed our dosing strategy in the Odyssey phase 3 trial. So this is Odyssey HCM. This is going to be the non-obstructive large trial for mavacamten versus placebo. Inclusion criteria is listed there, but basically symptomatic and not obstructive. We need 420 patients, and we're up to 110?
We are more than 25% enrolled.
Good,
yes.
so we've got
more than 110.
Got a ways to go. Primary endpoints for this study, KCCQ and peak VO2. So interesting endpoints. This is a much needed study, and we're looking forward to getting it fully enrolled. The next study I want to just touch on, because we are here at HFSA, is looking at mavacamten in a group of patients with HFpEF. This is a phase 2A study. It is a dose-finding kind of exploratory study. You can see the inclusion criteria, which is kind of like a little bit of hypertrophy. Not quite to the extent of HCM, but your heart kind of looks a little thick, as opposed to the other HFpEF patients, which might have no concentric hypertrophy. These are kind of patients on the spectrum of HFpEF who may be HCM-like, large left atrium, some concentric hypertrophy, elevated NT-pro. And this study is still enrolling. As you might imagine, it's kind of a hard group to locate, but if you're a heart failure doctor, you have a couple of these patients, might consider it. This is the Redwood cohort 4 that I have pictured here. These were data presented by Dr. Masri. And these are the open label cohort of patients with non-obstructive HCM treated with aficamten. Preliminary results show improvement in biomarkers and improvement in NYHA functional class. These were patients who were allowed to stay on their standard of care, aficamten added on top. On the basis of this cohort 4 study, we are now also enrolling for the Acacia HCM study. This is going to be the large phase 3 study, non-obstructive HCM for aficamten. So we have 2 trials, both of them 400-person trials, with non-obstructive HCM to enroll in the next couple of years. There are other novel treatments for HCM that are underway, including the very first gene therapy trial. This is for patients with myosin-binding protein C-associated HCM. And I think we'll see novel applications of other established therapies coming in the next couple of years. So we took a population, non-obstructive symptomatic HCM, with no options, and now there's quite a few options.
And yes, the first patient in the gene therapy trial got dosed a few days ago and is hanging out 2 miles east of here.
Congratulations, Dr. Desai. A major feat. So follow-up to polling question number 4. A patient with non-obstructive HCM, EF 60%, has insufficient symptom relief on a beta blocker and a diuretic. Which medical therapy do you now offer next? Disopyramide, aficamten, mavacamten, valsartan, enroll in clinical trial. I'm not sure. All right, so most people now selecting enroll in a clinical trial, which I agree. I think it's really a good time to be a patient with non-obstructive HCM. You have options at least for clinical trials. The other medication I would consider is an SGLT2 inhibitor in these patients who are symptomatic and congested. So key takeaways, and hopefully we have time for a few questions. Multimodality imaging is recommended to diagnose and stage HCM. Most patients end up with echo and MRI at least. Multidisciplinary management is really essential for patients with HCM, and adequate imaging capacity in your echo lab is needed to follow patients treated with mavacamten. Come to Dr. Desai, he'll give you a business plan. We know that mava has sustained effectiveness through 120 weeks in the obstructed population, including a reduction in the need to pursue SRT over 56 weeks of data. A second CMI next in-class agent, aficamten, is currently in clinical trials, not yet FDA approved for both obstructive and non-obstructive HCM. And we'll see if these agents have applicability to other disease phenotypes. So let's stop here and take some questions.
Yes. Thank you. So there are some pre-registered questions. Is mavacamten exclusively used to treat patients with MY87 pathogenic mutation or applicable to all HCM patients?
I'll answer that one. I'm giving you the imaging one next. So no, we find that there is benefit in patients who do not have genetic HCM. So you don't have to have a pathogenic or likely pathogenic sarcomeric variant in order to benefit from mavacamten. There was a small portion of patients in Explorer who did have disease-causing variants, and we'll see that data presented, I believe, at AHA by Dr. Ho. But we saw significant benefit even in those who do not have genetic HCM. It's the pathophysiology of obstruction that leads to the benefit in many cases. So the next question, septal thickness. How is it measured by echo? Leading edge to leading edge or inner edge for HCM?
Neither. So I would strongly recommend reading the ASC guidelines or EACVI guidelines. And most recently, there was a position paper written by ASC. Full disclosure, I was a co-author, which goes through details of imaging in hypertrophic cardiomyopathy. The important thing here are the 2-3 things that we have to consider. Where exactly you measure according to the ASC convention, number 1, and number 2, recognizing that you're not tangential, you are perpendicular to the plane of the septum, number 2. And number 3, on the right side, in the septum, it is important to recognize where the right side begins, because there's a lot of trabeculations more often seen on the right side. So often the sonographers will go the full extent, so you have to be able to recognize the trabeculations on the right side. So these are some of the important things that need to be taken into account. The leading edge to leading edge, or the is more applicable to aortic aneurysm measurements, definitely not in this case. There's a little bit more science and finesse involved here. So will these myosin inhibitors stop progression of the disease, the disarray of the myocardium, and hopefully long-term outcomes?
We don't know yet.
Yes.
So we need long-term data in order to assess that. We do have some longer-term data showing that there is remodeling occurring. And by that I mean by cardiac MRI. We have data that there is a decrease in left ventricular mass index, decrease in septal wall thickness, decrease in left atrial volume index. So all of those signs tell us that the heart looks more compensated. It looks like it's improving in those imaging parameters. But we don't yet have long-term data to show whether or not this is going to be altering disease progression and the trajectory of the disease.
Yeah. And time will tell. Look, you saw the time graph by Dr. Owens. The action started in 2018 or so. We are barely 5 years into this. So, Rome was not built in a day, neither was Cleveland. So change in severe MR due to SAM in patients with obstructive HCM treated with mavacamten. The answer is yes. If you relieve out, the biggest thing you see from an imaging perspective is SAM. Mitral valve does not close, so there's a posteriorly directed jet of MR. So if you reduce obstruction, reduce SAM, MR does go down. And there are a couple of imaging publications, one from the VALOR study by Kremer and colleagues, and the other one from the EXPLORE by Hegde and colleagues, if I'm not mistaken, which demonstrated that these parameters improve with treatment of mavacamten.
Here's a good one for you, Milind. Would you consider mavacamten in an asymptomatic patient who has a gradient close to 90? How do you assess that?
So somebody with a gradient of 90 who comes into me and tells me they are asymptomatic, for me, that's a starting point for negotiation. I'm going to tell them to prove it to me. We've published data. 428 quote-unquote asymptomatic patients come to Cleveland Clinic for evaluation of HCM, obstructive HCM. Prove it to me. Put them on a treadmill. About 50% of them do not achieve what is expected age-gender-matched exercise capacity. So yes, I'm totally asymptomatic, except I don't go to visit my daughter who lives on the 3rd floor because the elevator is broken. I'm just a grandma now. Why do I need to climb that hill? So yes, I'm not symptomatic because I don't no longer climb the hill. So, it is important for me to believe the patient is asymptomatic. They have to prove it. And if that's the case, then, all glory to them. Let's continue with current standard of care. CMI or newer therapy, first of all, that has only been around for as long as it has been, as short as it has been, with the price tag, the REMS program, et cetera. I don't want to put a truly asymptomatic person through any therapy beyond basic lifestyle measurements, lifestyle adjustments. But most people don't realize that they're symptomatic. I think that's the punchline here.
Absolutely. We see that time and time again. Any questions from the audience? We're at the hour here.
Yes.
Great. Thank you all for your attention.
Enjoy the rest of the day.